Sorry. All right, welcome everyone, and sorry for the initial technical difficulties. My name is Ramnath Subraman. I'm an associate professor in the Department of Public Health and Community Medicine and the faculty lead for our Global Health Seminar series. This series is co-sponsored by the Global Health Faculty Council here at the School of Medicine and the Center for Global Public Health. This is our final seminar for the academic year under our theme, Addressing Social Injustice and Global Health Through Advocacy and Solidarity. Our speakers this year have spanned a range of topics, including Pedja Stojicic, who talked about health activism, Dr. Duncan Marr, who talked about resources and power in public health, Rukmini Srinivasan, an Indian journalist, who talked about health in India by the numbers, Dr. David Gut, who talked about schistosomiasis, and Madhu Pai, who talked about allyship and global health. Note that these talks and prior talks are available or will be available. There's a little bit of a lag on the Center for Global Public Health website, which is sites.tufts.edu/TuftsCGPH. With all of these talks, we aim to address critical issues in health equity and embrace the university as an open space for being able to discuss challenging social issues. And in that light, I'm excited to introduce our speakers for this final seminar of the year. So I'll introduce all three, and then I'll hand it over to Yara, who will be our first speaker to sort of drive us forward. So Yara C. PhD is an assistant professor at the University of Central Florida in the School of Health Management and Informatics, and a visiting scholar at the FXB Center for Health and Human Rights at Harvard University in her capacity as co-director of the Palestine Program for Health and Human Rights. She was also a Fulbright U.S. Scholar to the West Bank, a non-resident fellow at the Arab Center in Washington, D.C., and a non-resident fellow at the Foundation for Middle East Peace. Her work focuses on health development, human rights in fragile and conflict-affected settings. Dr. Bram Wispelwey is an associate physician in the Division of Global Health Equity at Brigham and Women's Hospital and an instructor in medicine at Harvard Medical School, and he also teaches at the Harvard T.H. Chan School of Public Health. He is a co-founder of Health for Palestine, a community organizing initiative in Palestinian refugee camps that seeks to maximize wellness and address health barriers via social accompaniment and creative integration with existing facilities. And Dr. David Mills is a pediatric emergency medicine physician and fellow in global health at Boston Children's Hospital and an instructor in pediatrics at Harvard Medical School. He is an affiliate in the Religion, Conflict, and Peace Initiative at the Harvard Divinity School and a member of the Children in Crisis Working Group at the Harvard Humanitarian Initiative. Since 2014, David has worked in occupied Palestinian territories in partnership with local and international organizations to implement health capacity building programs in pediatric emergency education and research. And so I'm really excited to have these speakers, and I will hand it over to Yara to take us away. Thank you.
Thank you so much. Thank you for having us to discuss this today as part of your series. We're really excited to be here and take some questions at the end. I am just going to start sharing my slides. So today we will be discussing a structural approach to Palestinian health, and I'll be joined by my colleagues at the Palestine Program for Health and Human Rights later in the presentation, Dr. Mills and Dr. Wispelwey. So we have limited time today, so I kind of want to get right to it. And I can't see any of you. I can see a door, but I am assuming that there are people there. So hello. So I first want us to consider, as I start kind of framing this presentation, why a structural approach to health is needed here. After all, I think for any of you who are familiar with conflict health or however humanitarian health, however it's framed, it's kind of obvious and understandable what health looks like in this context. But Palestine is largely presented not as a context of apartheid, despite increasing classifications as such, or settler colonialism, despite increasing calls as such, but one of just tragic conflict. But conflict as a term does not really tell us much about the parties, their history, their historical or contemporary dynamic. So it's pretty easy for us to understand that in conflict, things like hospitals getting bombed, supplies being limited because trucks are blocked or supplies are bombed or whatever. And sometimes you will see this rise in trauma-related injuries due to shooting or bombing or whatever happens to be going on at the moment. And in fact, we've seen a lot of this happening in Palestine, especially in recent months. If you've been watching the news, we've seen almost daily or weekly raids. We've seen some resurgence of bombing in the Gaza Strip. We've seen just kind of random attacks, shooting attacks, restraining, all sorts of other violent events. And from these headlines here, we can see that 2022 was the deadliest year for Palestinians in decades. And by now, just early April 2023, it's already this year is looking much worse in terms of direct violence. But what we're here to talk about today is how there's a distinct difference between this kind of typical destruction of a health system, as has been so, documented in Palestine and other places like Syria, like Yemen, recently in Ukraine, and the targeted destruction, the targeted de-development, and on top of the harsh restrictions applied to the Palestinian healthcare system. So as I mentioned earlier, we've seen in recent years, many credible human rights organizations like Human Rights Watch, Amnesty International, Israeli NGO B'Tselem, affirming what many Palestinians had said for decades, which is that all of these restrictions and violence and oppression is likened to an apartheid regime, right? That this is purposeful. And in this case, we recognize that it's not domination for domination's sake. It's not just what is often referred to as protracted conflict. It is a series of political and economic and social structures that were created to support the dispossession of Palestinians and the seizure of Palestinian land. And so all of these structures, in very complex and overlapping ways that we could spend weeks talking about, ripple into Palestinian health in various ways. And it is these structures that we have to understand and use as our frame of reference when we talk about health. And today, specifically, we're talking about health in Palestine, but in really all contexts of public health, when we talk about disparities or inequities, inequalities, we really need to recognize that we're just here looking at the downstream outcomes of much larger structures. And that if we really want to make an impact on improving people's health, it's not just more humanitarianism, it's not just aid, it's these structures that we need to address and in many cases dismantle. So when the state of Israel was created in 1948, hundreds of thousands of Palestinians fled their homes, most assuming that they would be back, and thousands more were killed in massacres and other attacks. This is known in Arabic as the Nakba, or catastrophe. But most of these Palestinians never went back. They weren't allowed to. Their homes were taken over. Literally, other people moved into their homes. Their land was seized, often by what would be considered legal means by the occupiers. Their villages were destroyed and renamed. And this was all part of a widely stated, not hidden effort to make true this fiction that was propagated by the Zionist movement at the turn of the 20th century, that this was a land primarily empty of people. And if there were people, they weren't really a people that could be called Palestinians. They were just other Levantine Arabs that happened to be there. And even if there was a people, and if there were people there, they weren't really making the best use of the land. And so we needed other people to come in and really make use of the land. Whatever the justification was, the point was simple. They wanted the land of Palestine, but without the people. And this is why Palestinians and their allies have long said that the Nakba is not over. And what we want to talk to you about today is how the decades of purposeful restriction and violence have directly and indirectly impacted Palestinian health, including through mechanisms that ultimately affect the social determinants of health, like food and housing and environment. So for today, we'll be focusing primarily on the Palestinians and what are commonly referred to as the occupied territories. This includes the West Bank here, East Jerusalem in here, and the Gaza Strip. On top of occupation, the Gaza Strip has additionally been under blockade for 16 years. On this map here, you can also see in the West Bank these kind of two colors, which kind of represent the areas designated in the Oslo Accords. Areas A and B are these kind of light green colors. This is where Palestinians are supposedly afforded control and autonomy. But this tealish area here is all Area C, and this is under full civil and security control and makes up 60% of the West Bank. And we're seeing the area available to Palestinians increasingly shrink over time. So these are the Palestinian populations we'll be focusing on today. There are entire other conversations to be had about Palestinian citizens living in Israel, the Palestinian diaspora, like myself, and Palestinian refugees who are scattered not just around the world, but also within the occupied territories themselves. But for today, we will keep our focus here. So to set up briefly, just to give you an understanding of what is this health system that we're talking about, it has multiple stakeholders, including a Ministry of Health that was established with the Oslo Accords in the mid-90s and other public entities, but with a lot of representation from a private sector, which is growing, an NGO sector that helps fill in some service gaps, especially for specific populations, and UNRWA, which is the UN agency established right after the Nakba for those Palestinian refugees. Yet, despite the complexity of the system, and we're dealing with a population of 5 million, right? This is not a ton of people. These services can rarely fully meet the needs of Palestinians. And this is in part due to the import restrictions Israel places on the Palestinian territories as part of their dual use policy. And this limits certain goods and resources from entering the territories, especially in the Gaza Strip, but even in the West Bank. And we're talking here about medical supplies, some forms of medical equipment. And so often Palestinians are unable to get the care that they need. And so sometimes they are actually sent to Jordan or into Israel or Egypt to receive care. And this is care that is paid for by the Palestinian Authority. They may either apply for a medical permit to receive this care. Those with personal funds may pay, medical tourism to go into Jordan or Lebanon or Egypt to get the care they need. And in some small number of cases, there are NGOs that pay for them to access the care they need outside. And in all of these cases, all of this kind of outsourcing of health limits the spending capacity and the resources of the Palestinian health system. And it also further serves to disconnect people from their system and from their the organizations that are meant to work for them. And all of the entities of Palestinian health, despite kind of being under this umbrella of a Palestinian health system, must work within the limitations of the blockade and occupation. And when we talk about blockade and occupation, I think typically these are talked about as political or economic issues, which of course they are, but it would be disingenuous, right, to not also recognize the manifestations of these issues and how they affect health. So just as an example, if you keep up with this issue and you recognize that home demolitions of Palestinian houses, especially those built in Area C, is quite common. And this is often referred to as, lack of building permits, this kind of very anodyne, bureaucratic administrative process. And it's we may not inherently tie it to health, but I think for those of you in the audience that are in the medical community, whether you're medical students or in public health or practitioners or scholars, I don't think any of us would be surprised, right, that these kinds of events have an impact on health, right? A negative impact on mental health. Is it surprising that people whose homes are demolished they're more prone to food and water insecurity, or that their children are less likely to grow up with access to good education or social support? Of course not, right? I think we do understand. So then this is a lens for us to look at these bureaucratic policies that are often posed as, with security justifications. They're not just part and parcel of a political problem, but they become a tangible and often ignored threat to health. There's also the issue of the movement restrictions, especially in the West Bank. So we have these series of checkpoints that separate within the West Bank. So you can be driving from one Palestinian village to another Palestinian village and have to pass through Israeli checkpoints. If you want to get into East Jerusalem or Israel from the West Bank, there are multiple checkpoints, specific IDs needed. And then, of course, there's a separation wall, which quite literally separates Palestinians living in villages from their land, from their schools, and sometimes from the nearest hospital that they have to access. And it's important here to recognize that the separation wall was deemed illegal in the early 2000s, and it is almost twice as long in length as the Green Line, which is the supposed border of the West Bank of this future Palestinian state as it was once envisioned. So here we can see, if you can see this map, you can see that in this very, very tiny territory of the West Bank, there are just a huge system of movement restrictions. So if you can, I'm not sure how large the screen is, but if you can see these little H symbols here, these are where hospitals are located, typically in and around big cities like Nablus, like Ramallah, like Hebron, Bethlehem. But if you can see a little bit closer, all of these blue little circles are gates. So the villages in the West Bank where they access main roads to traverse the rest of the West Bank, there are gates that the Israeli military can close that will prevent cars from entering or exiting the village. All of these kind of do not enter signs are different checkpoints. And in times of increased violence, they will erect more checkpoints, known as floating checkpoints. Sometimes they may let you pass, sometimes they may delay you, sometimes they may block you entirely. You have no idea of knowing until you show up. And then here you can kind of see this border of the separation wall and how it kind of carves into the West Bank. And so in this very tiny territory, we have so many restrictions of access to healthcare, quite literal access, the ability. I mean, it's not about whether you have money. It's not about insurance in these cases. It's about whether you can literally get from point A to point B. And this includes ambulances, and this includes people that need urgent, time-sensitive care and still must navigate these challenges. Again, all of this is posed not as a health issue, but as a political or security issue. And this is the kind of framing that we're hoping to dismantle. And then lastly, there's the settlement expansion in the West Bank, which is among the most potent forms of evidence of not just an apartheid system and not just conflict, but of ongoing literal settler colonialism. So in the mid-90s, when the Oslo Accords were signed that were supposed to lead to this Palestinian state, there was just over 150,000 settlers. Now, this is from 2018, it's estimated to be closer to 600,000, and some estimates put it at closer to 1 million and claim that the size of the settlements and the infrastructure required for them is actually undercounting the population. And while this again seems like one of those solely political issues, what this does is limit the land available to Palestinians, limit their access between places to travel, and also, you know, it has severe impacts to access to education, access to employment, and all of these trickle down into health. I wanted to look at this picture. I took this picture from my aunt's back porch in a village in the West Bank. And if you just look up this hill, this is a settlement up here. So I think sometimes people have in their minds settlements as these kind of like informal, small, you know, not permanent looking settlements. And yet, as you can see here, these are developed basically cities at this point. This specific settlement regularly dumps sewage and other waste down this hill into the Palestinian village below, which contaminates their agriculture, which affects their ability to grow crops for their families or to sell at the market. And in general, it's making raising wildlife and sustaining agriculture, which Palestine has traditionally been a very agrarian, rural-centered society. It's making this part of Palestinian life almost impossible. So again, this is one of those things where we hear the term settlements, we recognize that maybe it's a problem to the political issue, but we can see that in reality, it has quite tangible impacts on health as well. And so we can't just deal with in this specific case, the pollutants, right? That's not the primary issue. Oh, let's give the villagers some ways to clean their crops, or let's move their wildlife elsewhere. That's not the issue. The issue is that this entire structure of settlement is causing significant barriers and problems for Palestinian health. So I think, again, most of us in the health community, we recognize that health is the sector most directly tied to mortality. This seems so obvious, right? Well-being, ability to work and play and thrive and live the lives that we choose to live. And so when we want to study the control of a population and how exercise of this control of a population is managed, health presents us with a perfect sector to do that. And so although we lack a significant literature base prior to the Oslo Accords in the mid-90s, because a lot of the health indicators from before that period for Israel and the Palestinian territories were presented together, after the mid-90s, we started to see in earnest these kinds of really targeted studies on how some of these political and economic and social factors do impact Palestinian health, primarily led by Palestinian scholars. And so here you can look at some, the studies looking at health consequences of the movement restrictions, mental health consequences of home demolitions, looking at periods of in heightened violence, like in the Second Intifada, and what was the impact of that on health. So despite kind of the obvious ways we would think these impact health, these scholars were taking this a step further and saying we can actually measure how these supposed political processes actually are part of a larger structure and have tangible negative consequences for Palestinian health. So since the Oslo Accords, there has been a massive influx of humanitarian and development aid to the Palestinian territories. And so we did see in the 90s and early 2000s, especially, some significant increases in some of the ways we measure health, like life expectancy, like vaccination rates. Although we can see here that in many areas, the Palestinians lag behind their Arab neighbors, and especially lag behind citizens of Israel. And as with Israel still the occupying power of the Palestinian territories, and thus still subject to specific obligations for Palestinian health, this shows us that this is not just a study of disparities or of inequities. This is two wholly different populations that have access to two wholly different health systems. Again, by completely man-made, human-made structures that keep them separated and keep these health indicators where they are. In many cases, the very restrictions that I discussed earlier that are clear threats to health, from the permits, the medical permits, to the gates that close villages, to the home demolitions, all of this is posed in this security argument. And this is often the kind of feedback that we get when we present this type of work as well. This is all for Israel's security, but it is this standardization and normalization of what can on paper sound like bureaucratic procedures, but they obscure that this is structural violence on top of the direct violence that we briefly discussed earlier. And it has, again, tangible impacts on Palestinian life that trickles down to health. And David and Bram later in the presentation will give a more focused look and with case studies about why that is. Before I finish, I just want to briefly address the social determinants of health as seen in the occupied territories, because we in public health recognize that the health of any individual or any community, any unit of people really, is dependent on a lot more than how and where they can access care, which we briefly talked about. So we need to recognize that these structures are more than just a threat to health, but they're a driver of negative impacts in the social determinants of health. So very briefly, just looking at economic stability, for example, 36% of Palestinians live in poverty. 26% of Palestinians in the West Bank and almost half of Palestinians in the Gaza Strip are unemployed. As a result, you see food security is low, and it's actually food insecurity is increasing. 23% of households of the West Bank and more than half of households in the Gaza Strip are food insecure, largely due to economic scarcity, not necessarily access to food. And these numbers are in large part due to Israeli restrictions. Estimates say that from about 2000 to 2020, the occupation cost the Palestinian economy at least 50 billion. So on top of the physical barriers to access, you have these barriers within the household where sometimes people simply cannot afford care that may be accessible. Moving on to education, Palestinians are not unemployed because they are not educated. In fact, they have some of the highest literacy rates, high school graduation rates, and college enrollment rates, especially when compared to their neighbors in the region, for both men and for women. In fact, in the occupied territories, the more highly educated you are, the more likely you are to be unemployed, because there are fewer jobs for people with advanced degrees and more opportunities in sectors like agriculture and in construction, including in Israeli settlements and including in Israel itself. Many highly educated Palestinians then leave to find jobs elsewhere, and this includes medical personnel as well. And so it's very difficult, as David will discuss in a bit, I think, to get highly specialized care within the occupied territories, because after all those years of training, it's very difficult to then go work in an environment where you don't have the resources you need. You're limited in your ability to even access the facility where you may work, and your patients may be as well. I'll skip over health and healthcare because we talked a bit about this, and Bram and David will explore this more in their presentations. But so we can move on to the neighborhood and built environment. So due to building restrictions of where Palestinians can build, you're increasingly seeing, instead of these individual homes structured around villages, increasing cramped apartment buildings with very little green space for play, very few sidewalks for walking or running. There simply isn't room to have a lot of green space, and there simply isn't the amount of investment to build villages and cities that are responsive to, being outside. And then there's, of course, the pollution issues and the issues of environmental justice. The settlements have poisoned acres of Palestinian land used for agriculture and for grazing. Most of the water in the aquifer under the West Bank is diverted to Israeli settlements and Israel itself. And so we're now in a situation where the PA has to pay for water from Israeli private companies that is pumped from the aquifers under the West Bank. Lastly, we have the social and community context. And this is probably one of the hardest to measure, but we are seeing increasing research on this. People can find ways to deal with lack of access to water, to electricity, green spaces. People can get used to unacceptable circumstances, but the fragmentation of life itself in Palestine, even within the same family, is detrimental in ways that is very difficult for us to understand and measure and deal with when these structures still exist. It's a very stressful, traumatic place to live. Multiple studies have found this, and every day is a question as to whether you'll be able to access this road or get to school this day, or whether the doctor will make it to the hospital that day for your procedure, or whether there'll be beds at the hospital for your procedure, or whether you'll be stopped at a checkpoint. And if you are, will they let you go? Will they search your phone? There's so many uncertainties in Palestinian life. And many people, of course, have their own personal traumatic experiences of either seeing violence, experiencing violence, being incarcerated, having their home demolished, and the list goes on and on. So altogether, this is the perfect recipe for an unwell society. And that is unsurprisingly the result. And as I think we're hoping to show, this is the point. And so this is why it's important to recognize that health offers us a really meaningful lens into why it is so important to look beyond merely conflict or inequity as frameworks here and look at the larger structures that cause this harm and these inequities. I hope I was able to give you the foundations of that in this 25 minutes. And I know David and Bram will get into some more detail, and then we'll have some time for questions at the end. So I will pass to David, and thank you so much.
Right, great. Thank you, Yara. Can you hear me, Yara? Okay, perfect. So yeah, thanks again, Yara. And Yara did a really good job of really setting up the structures for us, including talking a lot about the historical, a lot about the political, which then gives us a nice background to think about a case example that I'll talk about that'll really drive home some of these points.
And we'll talk a little bit about this case example, seeking cancer care in the Gaza Strip. And we'll really walk through how patients in Gaza try to or attempt to access care and how these structures actually prevent them from doing so. You can advance the slide, please. Great. So just to give you a little bit more background, the Gaza Strip, as Yara mentioned, has been under an air, sea, and land blockade since 2007, imposed by Israel and also by Egypt. 1.2 or 1.3 out of 2 million of the population are actually refugees from, again, thinking about those initial historical events that Yara talked about, which is really important. And there's only 2 civilian entry and exit points within Gaza. One is into Israel through the Erez crossing, and then one is into Egypt through the Rafah crossing. And again, as Yara said, movement of goods and people and commodities is severely restricted, which has really led to what Sarah Roy at Harvard University has coined de-development, meaning that not only are the health services in a dire state of underdevelopment, they're actually purposely being held to a point where for political gains to actually kind of push Palestinians a little bit to the brink. And so we'll talk about what that looks like in seeking cancer care. And then finally, again, Yara mentioned the permit regime, which severely restricts and regulates movements of patients. And so we'll talk a little bit about why that's really important. You can advance the slide. You can click maybe four times. There's a couple of things that'll pop up. Perfect. Great. Yeah, we can just leave it there. So when thinking about receiving care in Gaza, so what are the big barriers? I just told you about a lot of the access issues, the severe restriction on movements. This leads to issues with supply chain. So there's inconsistent access to medications. There's a lack of, especially in the pediatric context, there's lack of supportive intensive care. And so if you really want to take care of cancer patients that are undergoing intense chemotherapy, you need to have supportive care to take care of these patients. And then thinking about education, as Yara mentioned as well, there's a lack of subspecialty training to be able to, again, take care of these patients. One, the education programs aren't available in Gaza, but also providers have issues leaving Gaza to get that subspecialty care. And so that leads to barrier to diagnosis. It leads to delays in treatment and over-reliance on referrals. Remember, if you can't get the care in Gaza, then you have to leave Gaza to get the care. And as Yara mentioned, there's a financial burden on the Palestinian healthcare system. It's something like 40% of the PA's expenditure on health actually goes towards paying for these referrals, which is obviously unsustainable in the long term. Slide. And so we'll talk a little bit about, so now if you can't access care in Gaza, how do you get care outside of Gaza? So there is 100 different types of permits that affect all Palestinian movements in Gaza and in the West Bank. A couple of those include patient health travel and also companion for health travel. So just to put that into perspective, if you're a 3-year-old and you're looking to obtain cancer care, you're going to have to travel outside of Gaza with an adult. At the time that I was in the Gaza Strip doing research around cancer care, some of the restrictions on that companion medical permit included requiring the companion to be over 55 years of age. So that already knocks out, mothers and fathers to travel. Then you're looking at grandparents who may not be able to travel for different reasons. And then now you're thinking about other community members. So there's also a psychosocial component to this, or a psychological aspect where, again, you're having children or others leaving the Gaza Strip without, their close family members to undergo this intensive therapy. The approval rates for these medical permits have been declining over the years. As you can see here, the numbers in 2012 was a 94% approval rate. In 2017, it's down to 54%. And what I'll show here is, this has real impacts on morbidity and mortality for patients. These are just a couple examples of reports that have been out there, but it's not infrequent that you see these types of reports coming out. A boy who's 10 and a woman who's 37 died waiting for their exit permit for cancer therapy. Okay. And you can imagine in this last report from the WHO, thinking about a 3-year-old waiting for 5 months to receive cancer care, just something that, in the United States, you would never think of. Okay. You can advance, yeah. And so this is a study that really eloquently describes thinking about how do medical permits, does this access to these medical permits actually impact mortality, or do patients die because they're not able to access these medical permits? The graph to your left, I'll just point you to the gray bar, which shows you the total number of unsuccessful medical permits that were applied for. As you can see, from 2012 to 2017, this is exponentially rising. The graph to the right is a Kaplan-Meier curve. So let me back up a second. So this study was done by our colleagues at the WHO, who looked to compare the survival of cancer patients that require Israeli permits to exit the Gaza Strip for healthcare. So what they did was they did a retrospective cohort study looking at basically stratifying 2 groups. They looked at a group of population of patients who received a medical permit, and then the group of the population of cancer care seeking patients who did not receive the permit on their initial permit review. And so as you can see here on the right, this is looking at the period between 2015 and 2017. You are at a significant increase in mortality if you don't actually receive that permit. And so it's a really, and just for those who want to know, this was there's a multivariable regression model to control for all additional covariates. So really isolating that the permit is the key here for this increased mortality. And so I'll just pose this question, and Bram will help us answer it. But so when we think about, these causes that are structural, in, thinking about the structural determinants of health, where should we intervene? On the left here is a causal cascade. These social forces, or these oppressive social forces, help to drive these social structures that are also oppressive. So thinking about the conversations we're having right now in the United States, thinking about structural racism. Structural racism is driving these social structures, the policies, the institutional racism that then leads to your social and community and individual health outcomes. Similar in this case. So these structural forces are leading to these permit regimes, the occupation that, as Yara mentioned so eloquently, are leading to negative social determinants of health, and as I showed here, are affecting those community and individual health factors. And so again, back to the question that I said, when the causes are structural, where do we intervene? And the real answer to that is yes, we just have to intervene on all levels. Yara, you can click one more time. And so basically what we want to do is, we obviously, especially as medical professionals, we are ethically and morally obligated to intervene on the individual or the community level, but we can't do that without also, again, ethically, without discussing and advocating for changes to those social structures and those upstream social forces. And so Brown will now give us an example of how do we do that? How do we intervene at the community level while also thinking about those social structures? Great, thank you.
Awesome. Thanks so much, David, and Tiara as well. And so, yeah, I'm just going to give a brief example. And really, this is going to build off a little bit, from a slide Yara showed earlier, really, which was the mass exodus and displacement of the vast majority of Palestinians in the Nakba. And many of those Palestinians are now situated in refugee camps in countries surrounding Israel, Palestine. So in Lebanon, Syria, Jordan, but also within the West Bank and Gaza Strip themselves. And so, in fact, 70% of the Gaza Strip, at least, is made up of refugees, and well more than a third of the West Bank as well. And so I'm going to talk about some of the communities and what they're doing to organize around taking agency over their own health in response to these social forces and structures that Yara and David talked about. And so I've had the deep privilege in working alongside some communities in refugee communities in the Bethlehem and now Nablus regions of the West Bank, and been training community health workers for the last 5 years to really address some of the barriers that they can within their own communities. And so we've been calling this movement the Help for Palestine. And really, it's really towards the development of a new model, right? One that isn't necessarily humanitarian or neoliberal in its approach, but is much more rooted in working with communities directly, right? Because as Lorenzo Veracini, one of the scholars of settler colonialism, talks about, one of the main ways of resisting settler colonial structures is to remain, right? Because if the goal is to displace people, being able to even remain in refugee camps is in fact part of the practice of resistance, so that until they can return home. Okay, next slide. So this is what Ida refugee camp looks like in the West Bank now, right? In the 1950s, it started as tents and then small cinder blocks built by the United Nations. And as the confines of the geographic space of the camp have not been able to grow, they've been building up, right? And a lot of these structures are probably quite unsound at this point, and they're really built and reached a max. All right, so there's this ongoing challenge of folks having nowhere else to go. And so you'll actually see in the refugee camps, sometimes they're much higher than the surrounding areas within Bethlehem and other areas. Next slide. This is what the dark purple is what Ida refugee camp looks like. This is the geographical space. It's very, very small in terms of how much land it's taking up. The pink is where our patients are located, and this is based on kind of how many visits we did. This was a couple years old now, but just to give you a sense of the coverage of the community health worker program to date. Next slide. And just to really drive home, right, because you think about population density and the relevance, certainly in the time of COVID, but just in general, Yara talked about green space, of which there's essentially none. The separation wall that Yara showed, the apartheid wall, cut off Ida camp from the only green space that it had. It's now surrounded on two sides with multiple guard towers and cameras, essentially blocking all access from any green space. As you can see here, these are the most population densities in the world. Dhaka, Mumbai, Manila, and you have Manhattan, and you see Ida camp 2 to 3 times population dense, and that's typical. This isn't even the most population dense refugee camp in the West Bank. Next slide. A study from the University of Berkeley Law School named Ida refugee camp the most tear gas exposed community in the world. Tear gas is illegal under the Chemical Weapons Convention, under international warfare, and so you can't use it in war, but you can use it domestically, right? And that's how Israel and the United States use it against resisting populations. And so a huge cause of health concern, but in fact, very little known, because not a lot of studies have been done. Not a lot of high quality studies have been done, again, for some of the limitations mentioned. Next slide. I'll go through this briefly, but just to say that diabetes is also really one of those diseases, very different from something like tear gas exposure or COVID-19, but it's deeply driven by colonialism and oppression. As you can see here, wherever you go in any settler colonial context, in particular, thinking also about the United States, you will see diabetes rates that are 2 to 3 times higher in indigenous communities than in settler communities. You can see that here in the US, also in Israel, Palestine. Next slide. And the argument really that we're trying to make is that this is not about, you can't just zoom in on the downstream factors, the individual, the cultural, right? As Yara explained, this is a captive economy in the West Bank. And so they've gone through a rapid dietary transition, among other things, that was completely colonially determined, not culturally determined, not biologically, not genetically determined. And that's what drives diseases like diabetes. Next slide. And just to hammer that point home even further, these are rates of diabetes by age. You can see the age groups going along the x-axis and prevalence on the y. The Middle East, North Africa region in the solid black line has the highest rates of diabetes in the world. You can see in Palestinians in the Middle Ages, even higher than that MENA average, right? And the dotted line is the world average. But what else do you notice? The oldest Palestinians have actually very low rates of diabetes, even compared to global average. Right? So something changed. Genes don't change that fast. The culture hasn't changed in that way, right? This was completely externally enforced, right? And I think this graph shows it really clearly in terms of what changed. This graph is now almost 10 years old. And so, but really that oldest generation of Palestinians grew up in a very different context before occupation, before the Nakba and being settler colonially displaced. Next slide. And so in thinking through how, you would develop a community program that could start to be informed by some of these principles, right? We didn't want to just focus on the biomedical component of diabetes, right? And so we focused mostly on chronic diseases. These are the big burdens of disease in the camp, but also to think through what are the other aspects that are driving this, the trauma and resilience component. One of our patients told us early on that the reason he wasn't buying his insulin, right, was because he was saving up all of his money to give to his son who was in prison. And that's another whole conversation of why also Palestinians who are in prison require so much money just to sort of get by, but that's the privatization of the prison industry and everything else. And then also thinking through political education and mobilization. Next slide. So, you know, this has been termed, this kind of approach as accompaniment or social accompaniment, because again, it's not just about these technical aspects, but actually being there and walking through, right? And these are our community health workers, are mostly young folks, you know, all of whom have at least a university degree or are working towards one, who are working with their community members, visiting them often, getting them to appointments, checking their blood sugar, their blood pressure, you know, organizing their pills, giving them extra medicines when they run out, and sort of walking through them through every stage of what are very complicated illnesses, as I'm sure everyone in this audience knows, and very difficult to manage, even in the setting of a wealthy country and wealthy health systems. Next slide. And, you know, this is just a sort of before and after. We did a study. This study was led by Dr. Asma Ramawi, who's now at the University of Michigan. And, you know, these were both the A and B show patients who had a community health worker and patients who did not. And at the beginning, they were about the same, right? About half of patients had their diabetes under control. And we looked at 19 months later, and go to the next slide, Yara. And, you know, surprise, surprise, it's been shown in many other parts of the world, including by some of my colleagues, Peter Roloff in Guatemala, folks in Mexico, many other parts of the world have showed the impact of community health workers in addressing diabetes, but never in urban refugee camps, never under settings of chronic violence like experienced here. And you can see now that more than 3/4 of our patients had their diabetes under control after 20 months. And again, that's just the social accompaniment in action. 1.4 drop in hemoglobin A1C. On my final slide, before we go to questions, you know, here, I just want to, you know, and I think this hopefully has come through pretty clearly, but just to sum up, right, that the issues here are not, you know, fundamentally a lack of resources, right? And even thinking through what a community agency and a health worker project like this is really telling us in terms of its success, is that this is not a humanitarian issue that needs resources to be solved. It is fundamentally a historical and political issue that requires a very different response, right? It requires a very different sense of advocacy to change it, because this is really happening all through historic Palestine. I close with this picture just to clarify, right, that this isn't just happening in Jerusalem. It's not just happening in Area C of the West Bank. This is a community of Palestinian Bedouin, the Nakab or Negev Desert, in what is now southern Israel, from just a couple of years ago, or had their homes destroyed, right? So these are citizens of the state of Israel who are also still actively being displaced. And again, with all of the fundamental ramifications that has on health, as we've tried to connect today. So thanks very much.
All right, everyone. Thank you for those really wonderful talks. And so I'll open up the floor for questions, and I'll also, I know there's some in the Q&A that I'll vet while people are coming up with questions. So I'll toss a couple of these questions out from the audience online, and then we'll go back to the room here. So the first one is, given the lack of job prospects for the highly educated, has there been a downward trend in the pursuit of higher education among youth of Palestine? I think, Yara, this would be a good one for you, since you touched so much on these structural determinants, including employment.
Yeah, actually, and thank you for the question. So what we're seeing is not a wide-scale abandonment of higher education, because Palestinian culture really values higher education and they see it as a pathway out of circumstances. So you're still seeing people going to college. Oftentimes, as I heard from young people there, they go to college because they can't get a job. And so sometimes, as we see with recession here in the US, you'll see higher college enrollment rates because you're kind of biding time till something else comes up, we are seeing still high college rates, some people dropping out to join the agriculture and construction sectors because that's more immediate money, especially for people who need to support their families. But unfortunately, what we're seeing is people who pursue these degrees, and especially once you get into graduate school or professional degrees, then feel compelled to leave the territory, either to get training with the hope that they'll come back, some do, some don't, or with the plan to move to the Gulf, move to Europe, move to North America, and try to build a life there instead. So we're seeing this brain drain of some of the youngest and most ambitious and most educated Palestinians, not because they don't want to be there. And many of them I spoke to emphasize that they would stay if they could, but they feel as though, especially with a degree in hand, they just simply don't have opportunities in the territories that would enable them to stay, build a home, raise a family, do what previous generations did under the current conditions.
Thank you. And I think the next one I'll address to Bram, which is the response of UN RWA to your community health worker program, and whether people are starting to think with it more broadly.
Yeah, and so we from the beginning we really wanted to think about the program as a way being connected to all the existing health providers that are there. So for UNRWA was sort of the primary for Palestinian refugees, as mentioned, right? And so they've been folks we've been collaborating with since the very beginning. And in fact, some of them are co-authors on the paper that I talked about earlier. I mean, of course, UNRWA was extremely strapped, first and foremost, in budget, right? In 2017, the Trump administration cut the US's portion of the budget to UNRWA, which was 30% of their entire budget, to zero. So upwards of $360 million of the budget cut to zero. And there was a lot of fanfare when Biden brought some of that back, but he only brought back half of what it was in the Obama years. And so you have these chronic budget cuts that UNRWA faces. And so the level of care they're able to provide is not, and of course, they would be the first to admit this. It's not sort of maybe the most ideal level of care that's out there. They do an incredible job, of mostly Palestinian run, agency in the field in the West Bank. But inevitably it's limited. And so folks try to get care from many different sources, from Ministry of Health clinics, from private and NGO sectors. It's available, and it's an ongoing issue, but certainly they've been very supportive of the work.
I'll come back to the final question here online in a second. I'll just take the privilege of asking one of my own. This is coming from my own sort of experience as an infectious disease doctor. So I'm thinking now about the pandemic, about the COVID-19 pandemic, and how it was experienced across Palestinian society, Israeli society. We of course all know, and within Israel, a lot of the data was sort of a global leader in learning about vaccination and high vaccination rates. What was the experience in terms of COVID-19, how that was managed in these highly dense settlements? As well as vaccine equity, which was a profound challenge here in the US. What was it like during the pandemic? And to any who would like to comment, Yara, do you have any?
Yeah, sure. I'll start briefly. This was one of the few times when Palestinian health itself actually made the news, because, as you said, Israel was so lauded as this global leader in terms of getting vaccines and setting up, infrastructure throughout the state of Israel for vaccinations. And then there was this, consistently brought up critique that as the occupying power in the occupied territories, Israel has an obligation to Palestinian health as according to the Geneva Conventions. Israeli politicians, including the Minister of Health, totally ignored this. They said that because of the Oslo Accords, they no longer had this responsibility to Palestinians, even though the Geneva Conventions state that no agreement within the occupied and occupier, goes over the obligations of the Geneva Conventions. So Israel instead made, I think, one or two donations of 5,000 or so vaccines to the Palestinians, but they did not offer to vaccinate them. In some cases, they blocked donations of vaccines from other countries. They were pushed by not just the international community, but the construction sector in Israel to eventually vaccinate the Palestinians living in the West Bank who go into Israel for work, because Israel's construction sector was struggling as these Palestinians were falling ill or unable to travel into Israel because they weren't vaccinated. So eventually they were vaccinated, but the situation in the occupied territories was really piecemeal. I mean, they got a couple, they got donations from China, they got donations from Russia. Eventually, they got some of the Pfizer and Moderna vaccines in there. It was very, step by step. There was no real global call for solidarity with Palestinians. And even though we knew that populations, quote, in conflict would be among the hardest hit by COVID-19 because of the cramped conditions, because of the inability to social distance, lack of masks, fill in the blank. So because Palestine is primarily a very young population, I think the outcomes of COVID-19, although the spread was certainly there, we didn't see as high mortality or other issues as a result. But it was a real, I think, lesson in the impunity afforded to Israel, especially regarding a time-sensitive health issue like COVID-19, and B, the inability of the international community to even abide by its own stated, forms of international law to compel Israel to vaccinate 5 million Palestinians. At many points, Israel had huge stockpiles of vaccines that were expiring because they had already vaccinated everyone, and yet they still either did not give them to Palestinians or gave them to Palestinians shortly before the expiration date, where they were kind of useless because they couldn't be stored, they couldn't be distributed. So I've written a lot about this. If people are interested, I'm happy to share in the chat or afterwards. But yeah, I think it was a huge example of a lot of the structures that we've talked about in this presentation.
I'm gonna take on just one more, synthesize a couple of these questions and then close, unfortunately. But I just want to pull across a couple of these questions from Lashira Nolan, Amir Maharba, and others. One is about how you navigate bringing awareness to occupation, to also the challenges in speaking out as people in public health, as healthcare workers on this issue, and talking about what is a critical health equity issue, while also not extracting it from the fact that all health everywhere is politically, structurally determined, as you've done here. How do you, as you've done, I think, very nicely today, how do you navigate language? How do you navigate speaking about the challenges that you see in Palestinian health and in your work? And I'll open that up to everyone, and then we'll close after that with apologies.
David, Bram, do you want to start? I can't see you, so I don't know.
Yeah, I'm just trying to think of too exactly which part would be most useful to kind of comment on. I think, I mean, I think the language we use matters, right? In the sense that even to be able to understand something, to be able to then do something about it, you have to really be able to speak it and to be able to correctly identify it. And so I think, I just think it's important to continue to frame things in the way that most accurately represents reality, as uncomfortable as that might be, as many difficult conversations as that might raise, many tensions as that might raise. And I think those are all real, right, in terms of like this specific issue, as with any, but I think there's definitely special components with this one, and much more to say there, but that's the kind of key point I wanted to mention, is that I do think we've been very thoughtful and careful, I think, about the way we wanted to frame this, and even the structural framing itself, and part of that is to sort of push back against what we would consider hegemonic discourses on this topic.
I'll just briefly add, I think health offers us opportunities because it is such a evidence-based discipline. Everything we've presented here today, there are countless studies that confirm these in many, many ways, and there's still much work to be done. And if people don't like the outcomes, then I think they should examine why Oftentimes anything pro-Palestinian is seen as anti something else. And I think that we have just gotten so caught up in really unhelpful and sometimes racist tropes about Palestine and Palestinians. Even the fact that it can't be talked about like any other conflict would be talked about. And again, I use the term conflict, I can't avoid it, is something that we should question. We are an evidence-based discipline, medicine and public health. And so I think we should not be afraid of presenting evidence and saying this is what needs to be done. I don't think you can argue that detaining children and demolishing homes and having permits and checkpoints is good for people. You can't, and no one's even really trying. The question is, well, we prioritize the health and security of one population over the health and security of another, and then insert random political or historical justification here. And I think what health makes clear is that that's just insufficient. And, from whatever little corners we can kind of tackle these house of cards arguments, we should do so. And I think health offers us an opportunity to do so, as does education, as does incarceration, as does looking at homelessness. There's nothing wrong with discussing this. And I think the fact that people even feel hesitant or shy to be vocally support Palestinian human rights, I think is something that we really need to examine, especially here in the West. And so if health offers us an opportunity to do so, then I think, and what we're trying to do with the Palestine Program for Health and Human Rights is do exactly that. Use evidence to say there are wider structures at play here that we need to investigate.
With that, it's very eloquently said, Yara. And I just want to give another round of applause to our speakers and just to say, in the seminar series, we try not to shy away from challenging issues that need to be discussed, as our speakers have done today. And as the Palestinian American intellectual Edward Said said, there's the permission to narrate, opening up a space for people to narrate is really profound and critical. And so I thank our speakers for doing that today. And thanks everyone for joining this Global Health Seminar.
Thank you, everyone.